So the clock has turned, and as people dial in, we will begin. So welcome all to the second of 3 high-stakes conversations on the vital role of medical oxygen. This time we're talking oxygen and the Sustainable Development Goals for Health. My name is Leith Greenslade. I'm coordinator of the Every Breath Counts Coalition, and I'll be moderating the next 90 minutes. There'll be plenty of time for dialogue with you after our 4 speakers present, and we encourage you to drop your comments and questions into the chat as we go. We start today by making a very big claim that medical oxygen is an essential treatment for 8 of 9 health SDG goals. There you can see the picture there. The only one missing there of the main SDG health goals is 3.7, which is reproductive health. Now, if you can think of another medicine that hits more health SDGs, please tell us in the chat. We want to know. But that's where the good news stops, because medical oxygen is an essential medicine that remains scarce in many, many health systems, despite COVID-19 and the efforts of many of you and your organisations. At the same time, almost all countries are off track to achieving the health SDGs by 2030, according to the latest independent report from Jeffrey Sachs and his crew. They've just published that, and of all 194 countries, only 2 are on track to achieve all of the health SDGs, which means pretty much every country is looking for strategies to make fast progress. And our claim today is that oxygen is one of them. So you're going to hear from 4 speakers, and each of them will take on one of the SDGs. We can't cover all 8 on this call, but you'll get a good deep dive into 4 of them. They'll speak for 15 minutes each, after which we have a good time to dig in here. So please be prepared to contribute during that half an hour session at the end. We're going to start, let me stop sharing my screen, and we'll see if we're joined by Arthur Quezera, who is our first speaker. Terrific, we are. So we're going to kick off with Arthur, who many of you will know is a huge leader in access to critical care on the African continent and beyond. He's an anesthesiologist and critical care expert from Uganda. He has affiliations with the Great Makerere University and Malago National Referral Hospital. He knows more than most about access to basic critical care in low resource settings, and oxygen is a key component of that. So we've asked him to come and share with us his thoughts, his perspectives, what's working, what's not. This is relevant for several of the health SDGs because surgery, of course, cuts across many. So welcome, Arthur. You should be able to share your screen. Arthur, let's just make sure we can hear you as well. Terrific. Arthur, we can't hear you.
Can you hear me? Sorry.
That's okay, no problem. We can hear you now.
Okay, let me just, can you see my screen, please?
Yes, we can see your screen. Looks good.
Okay. All right, thank you so much for inviting me. I just happened to be on the road from a very rural place in Uganda where we've started what we call a community critical care project, trying to bring critical care closer to the village communities. My talk today, when you asked me to talk about this, it was quite interesting because one of the discussions we've been having in Uganda was about access to oxygen for emergency surgery, and of course there have been as you know, as everyone knows, that oxygen is scarce. We still have issues. We still have a lot of catching up to do in terms of adequacy of oxygen. So as I reflected on this particular talk, I wanted to give a voice of encouragement to people that oxygen and surgery are quite compatible, and my talk is going to focus on why on how we can, and the rationale why, less is more with regards to surgery. So I have no disclosures with regards to this talk. We know very well that 30% of all disease is surgical. And obviously it's worse in low and middle income countries. We have 80% of the burden of surgical disease, but only 20% of the global surgical workforce, which includes the surgeons, anesthesiologists, and nurses, and all the affiliated health workers. Then, and relevant to oxygen is the fact that 40% of patients who undergo abdominal surgery get postoperative respiratory complications that need oxygen. Now, the question we've been battling with, and this is where I'm coming from, the point of encouragement, that we actually don't need too much oxygen. The WHO had recommended that for patients undergoing general surgery, we would need to give a very high concentration of oxygen. That means a fraction of inspired oxygen of about 80% intraoperatively. And of course, and if feasible, even in the immediate postoperative outcome. However, a lot of data has since emerged that, and it's high quality evidence that shows that liberal oxygen therapy increases mortality without really improving patient outcomes. And this work was published in the Lancet by Derek Chu and others. And of course, even patients who undergo abdominal surgery that do not develop respiratory postoperative complications showed that there was actually a significantly increased long-term mortality, and appeared to be significant in patients undergoing cancer surgery, but not in non-cancer patients. So the other study that showed us that supplemental oxygen does not prevent outcomes with regards to major infections and healing-related complications. We have spoken about in other places we use hyperbaric surgery, hyperbaric oxygen for wound healing. But you see, it's really about hyperbaric means that it's oxygen under pressure, and that's different from supplemental oxygen during the intraoperative period. And then again, more data showing that high intraoperative oxygenation in patients during undergoing surgery was associated with major respiratory complications and 30-day outcomes. So the background is basically the fact that if you give too much oxygen to patients, we have, this is some basic medical science, we get reactive oxidative species that can cause damage to DNA, proteins, lipids, and subsequent cell death. I won't bore everyone with this, but there is emerging the concept of oxygen toxicity and hyperoxemia. So the reason why for a long time we've had this dogma that came from the WHO was because oxygen is commonly, continuous monitoring of oxygen is commonly done with pulse oximetry, and it's your final marks is 100%, and everyone likes that number 100%. However, if you use arterial blood gases, which we routinely don't have, you will find that a patient who has oxygen saturation of, let's say, 98%, two different patients with oxygen saturation 98% will have, one might have 400 millimeters of mercury in the blood, another might have 300 millimeters of mercury in the blood, depending on their oxygen dissociation curve. But when in reality, we only need at least 100 millimeters of mercury of oxygen concentration in the blood for adequate oxygenation. Now, the only possible solution for that is that new technology and new ways of judiciously measuring or targeted oxygen therapies. For example, the oxygen reserve index that's being developed by others to help us make sure that we don't give unnecessarily high levels of oxygen to patients. Why am I saying this? I am saying this because there's other data that shows patients do well with even an FiO2 of 30. And then you start from a lower concentration of oxygen and then titrate higher if you're not happy with your oxygen saturation. The reason I'm saying this is to give you hope, is that one, when you start with lower FiO2 concentrations, you will find that you conserve oxygen, you have judicious use of oxygen, and you're able to treat more surgical patients with less oxygen. And then, of course, what you need to do is to continuously monitor these patients postoperatively, especially those who would be at risk of postoperative hypoxemic respiratory failure. And so this message is really to encourage people not to worry too much about giving too much oxygen, but to understand that a lower FiO2 of oxygen is safer for the patient, but also reduces on oxygen consumption, and you can plan better with regards to how much oxygen you can save and plan for in your health facilities. Thank you so much for asking me to make this presentation. I'm happy to take any questions. Thank you.
Great, thanks, Arthur. Yes, I think we have some time. I know that I said wait until the end, but I think we have some more time left. You didn't take all the time allotted to you. So let's have some comments or questions for Dr. Quezera. I'm happy to kick off. So you really raise a huge flag about overuse of oxygen and wastage of oxygen. And at the same time as a lot of new equipment, as you know, is being introduced into many countries, including Uganda, lots of PSA plants, lots more little concentrators, even liquid oxygen coming in. How concerned are you about overuse, the wastage point you made, but also potential toxicity to patients? Do you think it's something that governments and global health agencies need to be paying closer attention to? And how do you best control that? Is it about clinical education, or is there more that can be done?
Yeah, thank you, Liv. Yes, I think I've been quite involved in our own oxygen space, and we get into conversations with leaders of health facilities who are trying to procure oxygen, and their biggest worries are how to how to distribute and how to prioritize where more oxygen should go. So there's always that conversation, or between children with pneumonia and then, of course, the surgical patients. And I use this data to encourage them to focus on patients who actually have acute lung disease. You know very well, obviously, Uganda has been doing a scale-up plan. We just completed the new scale-up plan, and we are setting up PSA plans around the whole country. We just finished a large clinical trial that focused on high-flow oxygen therapy for patients with ARDS, and we are now embarking on an obstetric trial and a pediatric trial as well. And these are lessons we are learning that and to help us and the rest of the world. The other thing you alluded to is clinical education. Sessions such as this we can have them more and more, over and over again, to continuously hammer home the message that judicious use of oxygen is the best way forward, especially in resource-limited settings and even in high-income settings. The data is still coming through with regards to, it's still a lot of it is bedside, but the data I've shared shows an association of bad outcomes with high oxygen, with high FiO2s. There is some physiological data that is emerging that is showing pulmonary oxygen toxicity. I'm hoping that later that there will be some hard evidence that points to this. So in the meantime, we really have to be cautious and not give more than we actually should.
So we have a question from Mary Kaplowski. Are these studies and numbers that you're mentioning based on healthy patient populations that don't normally require supplemental oxygen?
The data I'm sharing is in surgical patients. Healthy population. It's mostly patients who present with non-ARDS, non-acute lung injury for surgery. And the data is showing that in any case, so they have healthy lungs, but then they undergo surgery and are given unnecessarily high concentrations of oxygen. So obviously and those are patients. That's the bulk of patients who present to the operating room. It's very in the ICU, patients who have acute lung injury. Yes, more. It's a different scenario. But in surgical patients, most of them present with healthy lungs and still have bad outcomes because, which are association is not causation, but there's a very strong signal for harm in giving too much oxygen or unnecessarily high concentrations.
Okay, thank you. Other questions, please put them into the chat. You mentioned at the outset of your presentation WHO, and we have an expert from WHO who will speak later. But do you think the WHO needs to change guidelines or provide extra guidance on this issue?
I believe so. This work, I mean, I'm not even criticizing them. At that time, there was not a lot of evidence that, I mean, that I've presented right now. A lot of the evidence came after WHO published. So the expert panel did a good job. They started doing their work around 2014, and they published the recommendations around 2016. There are studies that show, there was a study that was done in the UK that looked at perioperative oxygen practice. Most anesthetists don't go above 0.5 FiO2, which is way lower than the WHO recommendation of 0.8. So I think yes, it's time to look at this again.
Okay, that's a clear recommendation. Any other final comments for Dr. Quezera or questions? I have to ask before we let you go, Arthur, are you confident that Uganda, that the ICUs in Uganda or critical care infrastructure in the Uganda health system, that the needs for oxygen, how far do you have to go to close remaining gaps? Do you want to put a number on it? Are you 60%, 70% there?
You know, yeah, that's a very good question. So we have, the Ministry of Health has a relatively ambitious plan. To build, to set up new intensive care units at the regional referral hospitals by 2026. That is the goal. But you know, in terms of as with all this emerging evidence, you know, there's a lot that I am learning about my own country that I didn't know, you know, before COVID, for example. We are, like I said, we are now thinking of bringing critical care to the communities, closer to the communities. And one of the things that the trial taught us that, you know, if you train medical officers and nurses, they can, you know, judiciously administer life-saving high-flow oxygen therapy for patients that need it. And we didn't think about this before COVID. I mean, COVID taught us quite a number of things. And the ARISE trial taught us that, you know, it's quite possible to do this. So now there is a project that we are going to embark on, where we're going to pipe, using the manifold system, pipe 250 wards around the country, so that, you know, it's about quality assurance, bringing oxygen closer to the patient. So if a patient on the ward is a medically ill patient, presents with, let's say, you know, what it might be a simple pneumonia, and then suddenly deteriorates, you don't need to think about intensive care. You can start by giving them oxygen according to the protocols that we've developed, and hopefully reduce the need for intubation and mechanical ventilation. Yeah. So 2026 for intensive care, but there's a new paradigm that we are developing and working on that you may read about quite soon.
Oh, exciting. If you can share any links with us, if there's anything we can look at now, we would please drop it in the chat. But we have a final question from Miranda Dixon. What can we do? What can our community do? We have quite a big global community on access to oxygen. How can we support the work you're doing with WHO, with any of the stakeholders?
Yeah, I think one, supporting, you know, education initiatives. One of the things that we're doing with our community critical care concept is, and I think I'll put my email in the chat so that someone can follow up, is we are trying to see if village health workers themselves can help in early recognition of critical illness. Of course, the major tool being around pulse oximetry.
Yes, yeah.
And because early recognition, many people know this concept, preventative critical care. Early recognition really helps in terms of preventing morbidity, mortality, and high costs of intensive care. So it's what I am trying to focus on right now. We've received quite a bit of help from partners abroad and around, but I think this concept is something that we can prove and hopefully roll out for adoption by other low-income countries.
Well, that's exciting. Preventive critical care and the critical role of the pulse oximeter in the hands of a VHT or community health worker.
Yes, yeah. What yeah. So the idea is to have, I mean, and this has been after quite a bit of reflection. If we build critical care, because oxygen is the core point of critical care, right? And if we center critical care around what oxygen is, so everything in the oxygen ecosystem, I think we can really, really, you know, the unintended consequences of investing in oxygen. For example, providing pulse oximetry, training people. You know, you can't just in isolation train someone to do pulse oximetry without teaching them how to take blood pressure, a respiratory rate, and a heart rate, and how to help them tie that in can be very useful. The patient might not be hypoxemic, but might be hypotensive. Maybe they have septic shock, and then they are still able to be picked up and hopefully along the referral pathway, and their life is saved.
Okay, so please drop you're getting some agreement in the chat here. So please drop your email into the chat, Arthur. And tomorrow, as everyone knows, we send a big email out to our network tomorrow summarizing each of our speakers, and we'll make sure you have Arthur's email, and we'll put some of his recent publications in. But just to underscore, if you're doing any work in critical care in low resource settings, you need to be talking to Dr. Arthur Quizera. So thanks very much. We know you're super busy, Arthur, for spending some time with us. Thank you.
Very kindly. Thank you so much for inviting me. I'll stay online and listen.
Oh, terrific. Thank you. That would be great. Okay,
Thank
so
you.
that was emergency critical care and the role of oxygen. Now we go up to the other extreme. We're talking chronic disease. So we have a really, really big SDG 3.4 to reduce premature deaths from chronic diseases. And this is the one area where I have to say, when we say most countries are off track, this is the area that's stumping, the dramatic rise in chronic diseases. And we have with us today Mike Hess, who many of you know from the COPD Foundation, based in the US, but with a global footprint. Mike's a respiratory therapist. He totally understands this field, and we've asked him to give us his take on the challenge. He's also I think of him as the sort of architect of World Oxygen Day, which will happen again this year for the second time. So Mike, if you have some minutes, we'd love you to give us the latest on World Oxygen Day at the end of your talk and how we can support. But over to you.
Absolutely. Thank you very much, Leith. I really appreciate the opportunity to, share some information with everybody today. And I appreciate everybody taking some time to sign into the discussion. And hopefully those folks who are also catching this in the recording will also get some benefit from this. So as mentioned, I work for the COPD Foundation. I'm a respiratory therapist by training and a public health advocate as well. This is obviously an issue that's near and dear to my heart. I lead our oxygen therapy initiatives at the foundation, including, as Leith mentioned, World Oxygen Day. So by way of a little bit of background, I would also contend that chronic lung disease is wildly under-recognized in general in the global health system. According to the WHO, we have a prevalence of about 10.6%, which equates to just under 500 million cases globally, and it's the third leading cause of mortality. More than that, though, you'll see that second bullet there, it's the seventh leading cause of disability-adjusted life years. And so what we're looking at with that, again, from the public health perspective, is we are taking quality of life years away from folks, which can impact their mental health, it can impact their community engagement, can impact the economy, the workforce, et cetera, et cetera. Obviously, it's a massive burden, and that's the burden of who we have diagnosed. We also know by statistical analysis about 30 to 50% of cases go undiagnosed because particularly in the early phases of a lot of these conditions like COPD, the symptoms are very nonspecific. It's cough, it's shortness of breath. It's the same thing that people would feel if and assume it's because they're getting older, or they're not in very good physical condition, or it's COVID again, or all these other things. And so we have a lot of diagnostic issues. And again, as we all know, equipment can be challenging in low and middle income settings. So not necessarily having the equipment needed to do that diagnosis. The cases, again, are anticipated to rise about, I believe if my math is right, about 20% by 2050. So this is obviously a heavy burden, and it's not expected to be going anywhere anytime soon. Another one of the common conditions that we will use oxygen therapy for is interstitial lung disease. And as you can see from the statistics there, it's not quite as heavy a prevalence, not quite as heavy a burden as far as that goes. However, the mortality, especially within 5 years, is much higher. And it does seem to be on the rise globally. We've had an 86% increase in ILD-related life years lost since over the last few decades. Now, to be clear, interstitial lung disease is a very broad umbrella term that covers a lot of different conditions inside the lung. And that also gives us some challenges as far as epidemiological data. We think we know the impact, but it's unclear. And especially as definitions can vary from country to country and even health system to health system, sometimes there's not a very clear-cut definition of this. So the burden could actually be much larger than we fear here. So what do we do for these folks? Well, of course, frontline therapy is, as with many conditions, pharmaceuticals. We also look at behavior modification in high-income countries like the United States. The leading cause of COPD in particular is exposure to tobacco smoke. That's obviously a major concern here. And then we're not quite sure what vaping is going to do, and then other inhaled medications, legal and otherwise. We also want to get people just basically trying to inhale as close to just air as they possibly can. We also promote a lot of exercise, which we'll talk about a little bit more in a minute. But also we need to consider environmental modification. I mentioned in high-income countries, the leading risk factor for COPD is tobacco, but in low and middle-income countries and in rural parts of places like the United States, it's actually exposure to biomass fuel, wood-burning stoves and other biomass exposure to that smoke is a huge component of COPD risk. So as we're trying to reduce that burden, we also try to get people using healthier fuels and healthier heating and cooking materials. And then, of course, as cases advance, we tend to put people on oxygen therapy with both COPD and interstitial diseases. We have issues with oxygen transferring across the alveolar membrane from the alveoli, from the air sac inside the lungs into the bloodstream. And so we need to push that equation a little bit more in favor of getting things across into the bloodstream. And actually, oxygen therapy is one of the precious few therapeutic modalities we have, particularly in COPD, that has demonstrated mortality benefit. These two studies on the screen here were actually both conducted right around 1980. One was in the United States, one was in the United Kingdom. These had relatively small study cohorts. There were 203 patients in the US study and 87 in the UK one. But even with that relatively small N, the researchers were able to show survival benefit, and these studies actually form the basis of oxygen therapy to this day. So it's actually pretty clear, especially in given certain lung states, particularly severe hypoxemia at rest. This is kind of the classic application for long-term oxygen therapy. Supplemental oxygen goes by a couple of different names, and that is defined as a PaO2 with a blood gas sample of 55 millimeters of mercury or less. But again, in a lot of these settings, as the previous speaker mentioned, blood gases are not often available. So we also look at pulse oximetry, and the rough equivalent to that is a saturation by oximetry of 88% or lower. We also see some benefit with supplemental oxygen for folks with who desaturate during activity to that same level. And so if you basically, the way this works is if you have that severe hypoxemia at rest, you're prescribed continuous oxygen. And if you have it during activity, then you are given portable systems and you are to use it as you're active. There is a little bit of wiggle room, particularly with demonstrated heart conditions. In that third bullet there, the third large bullet, looking at moderate hypoxemia, which is that 89 to 90% saturation. Again, as long as you have things like polycythemia or dependent edema that signal heart issues. How oxygen is delivered will vary widely. The arguable gold standard, or at least the most common way to deliver oxygen in the long-term setting, is compressed gas. This is very commonly used. We've seen news reports and everything else that this is where a lot of people are transporting their oxygen. Unfortunately, even sometimes in a facility, we use these tanks for ease of transportation or to support people who need acute therapy. But there are a lot of issues with this too. I shouldn't say there are a lot of issues. There are pros and cons to each of these modalities. One of the best things about compressed gas is it doesn't require any electricity to actually deliver the oxygen flow. Unfortunately, it is a finite vessel and only has so much to provide. So when that runs out, you have to switch out the tank and acquire a new one. As mentioned also a little bit previously, we have this idea of the oxygen concentrator, which can actually is essentially a molecular filter that takes ambient air, filters out the nitrogen, and compresses the oxygen down, which is then delivered through tubing in a nasal cannula, which can be used in a home setting, can be used in a clinical setting. These are increasingly common in a lot of areas that don't have the transportation infrastructure to get to move compressed gas tanks around. Unfortunately, these are a little bit more sensitive to power and electricity requirements and things of that nature. So again, pros and cons to each of these. And then the third major way Leif mentioned at one point was the cryogenic liquid oxygen, which is essentially hyper compressed down into a storage vessel, a high-tech thermos bottle, insulated bottle there. Again, some pros and cons, doesn't require electricity. However, these are very expensive to handle logistically, and makes it difficult to transport these over long distances. So again, there are a lot of different things to look at when we're considering oxygen therapy. And that's why I want to spend my remaining time here looking at where we have some opportunities for investment so that we can actually lower the burden of disease, get people active, moving a little bit more, and making sure that they have exactly what they need to maximize their quality of life. Again, one of the key things here is infrastructure in the supply chain. In low and middle income settings, a big part of the issue is, as I mentioned, getting oxygen from the plant, where they're super condensing the oxygen, packaging the cylinders and everything else, and getting that out to the front lines where it's needed. But we also see supply chain issues here in countries like the United States, where portable oxygen concentrators, you have smaller versions of that big stationary one that I mentioned, there are back orders, there are waiting lists. Again, we're not actually able to provide people with the equipment they need to stay engaged and stay involved and stay working and stay with their community and everything else. So we clearly have a lot to do with the global supply chain and building up that infrastructure. We also need to do a lot more with research, frankly. I mean, as I mentioned, those studies that form the underpinning of our current understanding of oxygen therapy are roughly 45 years old now. And there hasn't been a lot of movement since then. These studies tend to be a little bit difficult to conduct. There have been some since that have had difficulty with recruitment and everything else. But that's part of the challenge, because not only are they old, they were very specific. These are North American and Western European patients with specific disease states. Most of what we know about oxygen comes from COPD because that's the largest cohort. So it's difficult to extrapolate. Do other disease states really need different modalities? We know folks with pulmonary fibrosis and similar interstitial lung diseases tend to need higher flow rates, higher amounts of oxygen. We haven't really drilled down to refine how best to deliver oxygen in these different states, or even outside of adults. We know that a lot of kids these days, a growing number in particular, do need chronic oxygen therapy, long-term oxygen therapy. But we don't know how best to meet their needs because we haven't really done that research. So there are huge knowledge gaps that we need to work on filling. Education and training, not only of individuals using oxygen therapy and their caregivers, but also clinicians. We know that oxygen therapy, particularly in the long-term ambulatory setting, simply hasn't existed in many parts of the world so far. And this is a kind of a new concept for a lot of folks. And so we need to do some of the very basics of how do you apply and maintain a cannula with somebody? How do you keep it clean? How do you make sure that they're getting the right settings? How do you make sure you're changing out the filters and all the intricacies that many of us may be taking for granted in a developed healthcare system? We need to do that elsewhere in the world. But we also need to make sure people are understanding their equipment when they receive it. That's the biggest issue here in the U.S., and we're working on some policy reforms for that because people are never really taught why they're put on oxygen therapy, how to use it, what to do, and all those things. So another huge knowledge gap. Technological innovation, again, some of the scientific underpinnings of oxygen therapy are old. We're looking for newer ways to deliver oxygen to better concentrators, better delivery systems, and also diagnostics. Pulse oximetry has come up a couple of times already. It also has some major concerns with confounding factors. We know that there are different readings across the spectrum of skin tones that we haven't really reckoned with sufficiently yet. And we need to make sure people are aware of that as we start deploying new equipment into new settings. And then finally, we need to do better. We need more investment in public health communications and awareness so that people understand the issues, so that there's less stigma attached to this. A lot of people refuse to wear their oxygen therapy because it makes them, quote unquote, look sick, makes them look different. People stare at them. So they don't understand kind of the underpinnings of that. So we want to make sure that the general public is aware. We want to make sure policymakers are aware of the barriers to proper use of oxygen therapy. And then, as Leith mentioned, we have World Oxygen Day coming up on October 2nd, where we're hoping to develop a series of webinars, one specifically here in the U.S. focused on health equity and other concerns regarding, again, pulse oximetry and other respiratory conditions. We also want to work with global partners to do more local events so that we can really get the information out that is relevant to those communities under this World Oxygen Day umbrella so that we can all work together and make these improvements. So with that, I believe that's my time. I really, again, appreciate everybody coming out and learning a little bit today. And I'm happy to entertain any questions either as time allows or via email or other social media. I'm not too hard to find, and certainly Leith can connect us if desired. So thank you very much.
You bet. We'll be putting all your different social media channels in the email tomorrow. But that was a brilliant presentation. We do have time for a question or two. We have one in the chat from King Hong Gove. And the question is about the patient pathway to oxygen, depending on the cause, whether it's COPD, lung cancer, lower respiratory infection, tuberculosis. Before you answer that, I just want to say there's a mix there of the chronic and the acute needs. Although in high-income countries like the US and Europe, there are well-established pathways for someone with a chronic disease to get oxygen, I have to say, in the settings where our coalition members work, low resource, there's almost no discussion at all of the home care market, if you like, for oxygen. So even the countries that are doing their national medical oxygen plans in Africa and Asia, Latin America, typically they're talking about hospital oxygen for patients in acute distress. And the massive home care market for all their people with chronic diseases is untouched. So I just want to say that, Mike, you might want to respond to that question, but if you can also talk a little bit about the massive agenda in low resource settings to raise awareness about the needs of chronic patients who need oxygen.
Yeah, I mean, I think you said it. I think you said it quite well. I mean, the framework for long-term oxygen therapy simply does not exist in a lot of these places because it hasn't been contemplated because the focus has been on acute care because the idea is to keep people alive urgently. We solve the low-hanging fruit, so to speak, and those are the more urgent issues. So but as other therapies and other as surgery improves and medications improve and other therapies improve, we are keeping more folks alive longer who again could benefit from this. So that's really the challenge, is to develop some of these care processes and patient pathways. And the resources are going to be significant. We again need to, there's a lot of investment going on in creating there's been a recent development of a stationary concentrator, oxygen concentrator, that is a little bit more ruggedized for these settings where it can go on different power supplies and it's less sensitive to changes in voltage and current and so on and so forth. So we need that kind of investment, but we also need distribution channels. We need, again, that education and training to help clinicians in these settings identify those folks who could benefit from therapy better. in many places, as Leith said, we have our existing pathways in high income countries, but in many parts of the world, we need to build those. We need to adapt what we have and insert those into those settings. So, I mean, I guess I would love to cover it, but I guess it's a work in progress is the best thing I can say.
Okay, I'm going to take one more question, and then I'm going to ask you to drop the World Oxygen Day web link into the chat, because this is a global day and we all need to get behind it. But the question is from Lucio Brito, who's a Lancet Global Health Oxygen Commissioner, one of only 20, as well as an engineer, biomedical engineer, clinical engineer from Brazil. And he's asking a good question, I think, about your interface in the COPD oxygen world. What is the interface like with biomedical engineers and technicians? You've got all these machines in homes. What happens when they break? Does the system, have you seen a good system, Mike, to make sure that patients have access to people to fix the stuff?
Fortunately, in the US, we have I struggle with the word decent because there are days I don't even want to give it that much credit. A decent enough system, but we have a network of suppliers that are usually pretty responsive to folks who have issues. You can call your equipment supplier and they'll bring you a replacement unit or they'll trade it in. There are certainly logistical issues there as well. It would be great to have tighter relationships with that. Again, some of that is a policy issue. We have, with our infamous American healthcare system, reimbursement is always an issue. So that has put a lot of burden on some of these equipment suppliers, and they're not as responsive as they would like to be. Getting things repaired and everything else. So. And again, that's something we definitely need to build out, and I know that's been a big priority for Every Breath Counts to promote biomedical engineers in austere settings and everything else. So I do not personally have that joint experience, but I have several friends in the DME industry, both in the manufacturing side and the distribution side, and the more we can strengthen these connections and work together, the better off I think everybody is going to be.
Great. All right. Thanks, Mike. So Mike was talking about SDG 3.4, the massive effort to reduce premature deaths from chronic disease and the role of oxygen. We're going to move now to an area that's very close to the hearts of many of us working in public health, SDGs 3.1 and 2, maternal, newborn and child survival. And we have with us wonderful Professor of Pediatrics at the College of Medicine in University of Lagos, Dr. Chinyere Eziaka. She's also very much involved with NEST 360, which we all know that program. So Dr. Eziaka is going to talk about particularly oxygen and neonatal survival. So over to you, Dr. Eziaka.
Thank you so much, Leith. Let me share my screen. Please, can you see the slide?
We can see your screen, but not the slide yet. If you click on, yes, now it's coming. Yes.
Let me put the slideshow. Thank you. So, warm greetings to everyone. My great appreciations to Every Breath Counts Coalition for the opportunity for me to be sharing and having this discussion on oxygen and neonatal survival for us to all achieve SDG 3.2. Please permit me to stop the video now so that the bandwidth will not cut off.
No problem.
So, thank you so much. So, the outline is as shown on the screen. The oxygen need in the neonatal period, newborn contribution to under 5 mortality, oxygen and neonatal resuscitation from birth, components of an effective oxygen delivery system, and then look at technological innovations for newborn survival, the NEST 360 program. It was interesting listening to the last discussion around biomedical engineers and training and devices. And that is the whole highlight around the NEST 360 program. So today, we all know that SDG 3.2 is looking at, by 2030, to reduce neonatal mortality to 12 or less per 1,000 live births per year across all countries. And where many countries in low and middle income countries are still very far from this target. To say that oxygen need in the neonatal period is critical, it is crucial, it is a key life-saving intervention, that many conditions that affect babies in the first days of life result in low oxygen levels in the blood, and hypoxemia, looking at low oxygen in the blood and in the tissues, hypoxia, leading to respiratory failure, or actually the commonest causes of death in newborns. So this is a critical emergency, and supplemental medical oxygen is life-saving intervention that must be given to any newborn that is small and sick, right from the delivery room when needed. In the preterm population especially, both restrictive use and excessive oxygen administration result in adverse effects. So there's need to have that, to strike that balance and do no harm, because excessive oxygen leads to a lot of free radical, oxidative radical damage, leading to retinopathy of prematurity, blindness, and chronic lung diseases, bronchopulmonary dysplasia. Hence, there's the need for balanced, judicious use of oxygen in newborns. We have to have, in addition to the oxygen sources, to have blenders that will titrate and mix this oxygen with air so that we're not delivering 100% oxygen to our babies and causing harm. And then the use of pulse oximetry is mandatory, because we have to be able to promptly detect hypoxemia and be able to treat it once it's there. So looking at the magnitude of the problem, it's enormous. That 2.6 million newborns die worldwide, globally, and 1.1 million of these newborn deaths are in Africa. So this is a key issue. And what are the three main causes of deaths in newborns? We're looking at prematurity, with the antecedents of respiratory distress syndrome being a common complication in these preterms, and they need oxygen to survive, in addition to all the other complications. Then we also see infection with pneumonia. We have newborns having pneumonias, congenital pneumonias, etc. And then as a component of sepsis, you have pneumonia. And then the babies that have hypoxic brain injury, that have asphyxia. If these children do not have oxygen within the first critical minutes of life. So we can see that oxygen is a very key denominator across. And currently, as we speak about under 5, that prematurity has been documented, is now the highest cause of death in the whole of the under 5 age range. So this is very key. So I look at this data from the Nigeria and Every Newborn Action Plan to just drive home the fact around neonatal mortality, just opposing it to under 5. To see that neonatal deaths contribute on the average 32% of all under 5 deaths. And this is an average. In some situations, in some counties, it's as high as 45%. So the message is, as we're racing to SDG 3.2, except we prioritize and sort out the, with key actionable steps and accelerate action in the area of newborns, we may not be able to achieve SDG 3.2. And this is key, and oxygen is critically important. And looking at this neonate, we're seeing the preterm births, the intrapartum related problems, the asphyxias, sepsis, and pneumonia, congenital anomalies, etc. So quickly to say that ventilation, this is the chart, the algorithm for neonatal resuscitation, to say that oxygen and neonatal resuscitation in asphyxia are key issues, because this baby has to breathe. This baby has to transit from intrauterine to extrauterine environment without damage to the brain. So they need to target an appropriate SpO2 range from the first minute of life. But this has to be started with, it's advised that it's recommended that you don't start with 100% oxygen, 21% in 10 babies, which is room air. But incidentally, some of those babies that are now asphyxiated and compromised, you have to now titrate the oxygen and can get up to 100%. And in the preterm babies, you start with 30%, those preterms less than 32 weeks gestational age, so that you don't cause oxidative damage. So it is now mandatory that pulse oximetry is utilized from the first minute of life. So looking at this chart, you can actually see from first minute of delivery, SpO2 monitor, and then supplementary oxygen as needed. This is within 1 minute of delivery. So you aim for at least 80% SpO2 by 5th minute of life. And this monitoring is key. So by this chart, you're seeing targeted preductal SpO2 after birth. 1 minute, you're aiming for 60, you should be getting up to 60 to 65%. And by 10 minutes of life, you should have gotten pulse oximetry SpO2 of saturation of 85 to 95%. So this is a pictorial diagram to just bring some degree of reality to this, that in that crucial 1 minute, either the baby is breathing or this baby is not breathing. And unfortunately, this baby that is not breathing needs oxygen. And if oxygen is not available, unfortunately, this baby will fall within another category of stillbirths. We have many stillbirths across board, and in addition to the early neonatal deaths. So we have to ventilate within 60 minutes of birth, called this first 60 seconds of birth is called the golden minute, 60 seconds. And then you have to have availability of bag and mask and supplemental oxygen. These are crucial. Incidentally, unfortunately, many facilities in low and middle income countries don't have this bag and mask available, and they don't have medical oxygen available. So these are key, because this with SDG 3.2 may elude many countries. So there's a need to potentiate efforts. So we talk about requirements for safe oxygen use in neonates, which includes an effective delivery system, a non-invasive system for measuring, and pulse oximetry is now taking like the 5th vital sign with the target of 90 to 95%. And we should use the appropriate oximetry devices. The adult finger type, which we see for some neonates, being used in some facilities, is not appropriate for newborns. So we should also have staff who are trained and in adequate numbers to judiciously use oxygen within limits. So we look at these WHO levels of care, and we see that across all the levels of care, oxygen is needed. At the immediate level, level 1, we're seeing neonatal resuscitation to those who need it. And then you look at the special newborn care, you see level 2. Safe administration of oxygen is one of the key areas that every level 2 facility must be able to give. And oxygen is needed for this. And then you look at the transition, CPAP management of preterm respiratory distress. If we say that prematurity is the commonest cause of death in under 5, all under 5, then we must institute measures like the continuous positive airway pressure to manage these babies. And then by the time you get to level 3, you'll see mechanical ventilation, assisted ventilation. All these need medical oxygen. So in line with what the presentations that have been made, we're looking at key components of oxygen systems in hospitals, looking at starting from the oxygen source to the distribution through the cylinders, through the piping, and which many facilities do not have. Then the regulation, the conditioning, we actually see as components of oxygen system. We should also look at the regulator, the flow meter, the humidifier, the flow splitter. A flow splitter can split one source of oxygen to 5 babies. And these are equipment that are needed, devices that are needed in low and middle income countries for us to accelerate oxygen use. We should have blenders, CPAP, and ventilators. So all this should come as a bundle. Patient delivery, the nasal cannulas, patient monitoring, the pulse oximeters. And then what are the things that feed into it? Power supply, information, we look at how to get to have the data, we must have the biomedical engineers and technicians that are trained, that know about, so they will teach about the maintenance, the spare parts, the oxygen analyzers, for you to actually know what amount of oxygen, are you getting even from the oxygen concentrator. Then the staff, you need the staff. The biomedical engineers and technicians should be integral members of the neonatal teams, the newborn teams, nurses and midwives, and then to have education, mentoring, supportive supervision, etc. And so all this should come at a full comprehensive delivery for us to achieve SDG 3.2 in newborns. So this is one of the slides within the NEST 360 program that we talk about equipment graveyards. This is what we see in some storage in some facilities. These are mostly donated in low and middle income countries, oxygen concentrators. Some of these equipment just need a fuse. And if it is we stack all these equipment and are not functioning, the babies will keep dying and we won't be able to achieve SDG 3.2. So these medical devices cannot save lives if they are in the equipment graveyard. Furthermore, most hospitals lack the life-saving technologies and trained staff necessary to manage small and sick newborns. This is a template of a facility that has the NEST 360 program. These are CPAP machines, and these are the radiant warmer with a health worker looking after a very ill baby here. So these are not available in many facilities across many countries. So there's a need for us to articulate, come to the drawing board and put things, put all this together as a bundle to save babies. So now we will talk about, I've mentioned NEST 360 program, Newborn Essential Solutions and Technologies. It is an alliance of 22 organizations, 17 in Africa. And the program aims to ensure that every hospital in Africa can deliver life-saving care for small and sick newborns, currently in 5 countries, and to deliver a health system package, including a bundle of technologies to provide life-saving small and sick newborn care for us to meet both the SDG goals and every newborn action plan global goals, and to measure and sustain change. Overall, to improve newborn survival in African hospitals. This is a spread of some of the country members of these teams. And the countries currently are Malawi, Tanzania, Nigeria, Kenya, Ethiopia is coming on from this phase. And this is what we're speaking about, that we are to meet targets. The Every Newborn Action Plan target actually speaks about 80% of districts in every country should have at least one level 2 inpatient unit to care for small and sick newborns with respiratory support, including oxygen. In many countries, not up to 5% have, in many countries in low and middle income setting, have facilities for CPAP. Meanwhile, we have this global target that is by 2025. So this is where NEST 360 positions. And looking at level 2, special newborn care, respiratory support, oxygen use, in addition to CPAP. So we talk about a bundle because this is a baby receiving CPAP. This is an ill preterm baby. This baby needs respiratory support. This baby is getting oxygen, using an oxygen concentrator, using a pulse oximeter. In addition to that, this baby does not need only respiratory support alone. Also needs other very key care, jaundice, hydration, point of care diagnostic, temperature instability, etc. So there's a need to bundle care for newborns to achieve the desired outcome. So quickly, these are the spread of the categories of equipment, the devices, the ones that treat infections, radiant warmers for temperature, hydration, nutrition, manage jaundice, point of care diagnostics. And you can see the breathing support. So oxygen source is part of this key, CPAP, Suction machine, because a baby that's asphyxiated, a baby that is not breathing, you have to suction, but the neonatal suction, pulse oximeters, and then the monitoring devices. In addition to that, NEST is not just about the technologies. It's looking at a holistic support, national policy change, finance, pre-service education, in-service education, supervision and mentorship, and looking at the distribution channels. So these are clinical and technical training modules, which are available online as public-private goods. So this is an oxygen concentrator. This is a clinical module. Because now in the NEST facilities, the nurses know that every week you have to change the filter of an oxygen concentrator for it to give you maximal functionality. So these are important. And this is the biomedical SOP, troubleshooting and maintenance of an oxygen concentrator. And in addition, NEST has 49 skills labs across for skills training and pre-service education. It's also, of course, teaching biomedical engineers and technicians how to maintain and repair devices. Then data for action is key, and this is integrated within the government system. If you look at this, this column here, it's actually speaking about what proportion of babies have respiratory distress out of the total admissions, what proportion of these babies had low oxygen saturation, what proportion received oxygen treatment, what proportion out of the total admissions received CPAP treatment. So this data and quality improvement exercises is to drive change. So data and quality is key. This is the oxygen splitter I had mentioned, that is, if it's connected to an oxygen concentrator, will actually split oxygen across 5 babies. Phototherapy, the pulse oximeter, this is the pulmonary CPAP, this is a CPAP machine, and a radiant warmer. So interestingly, one other device that NEST 360 utilizes is a Hadley device monitor, meaning that it can track any of this equipment wherever they are, and through a dashboard, you will know whether an oxygen concentrator that you've positioned in a facility has worked in the past 1 week or has not worked, or when was it last used. And then it also tracks power outage, how much electricity was there in that facility and got to that equipment, etc. And this data is gotten real time. Looking at the numbers, Malawi has full coverage of the secondary facilities, Kenya 27 facilities, Tanzania 28, Nigeria 21, Ethiopia 16. So because the whole mission and vision is for the governments to take up this pilot and then take it to scale across all the other facilities, having seen the results and having seen the data that is being outputted from those facilities. And furthermore, NEST has worked with global stakeholders to develop an implementation toolkit, which is available for small and sick newborn care, bringing together learnings, tools, and for implementers to use and act and learn. And this is the website. Thanks. And these are my key messages. Low oxygen level is the commonest cause of death in newborns. Oxygen management begins in the delivery room. And this oxygen must be judiciously used within safe limits in the preterm babies to prevent toxic effects. And there's a need for availability of oxygen technologies, monitoring devices, and regulating devices like CPAP machines in order to meet global targets and for us to meet SDG 3.2. And then there has to be a sustainable financing for oxygen access. This is paramount because the parents currently are paying out of pocket in many low and middle income countries, and the cost of medical oxygen is excessively high. So denying many babies that will need this oxygen, this very important intervention. So there is need for health insurance to incorporate these life-saving interventions for newborns so that we all speak holistically. There's need to strengthen partnerships and collaborations and synergize for oxygen access and overall respiratory support. Because if you have oxygen and you don't have the drivers, so you have oxygen, CPAP, oximeter as the bundle, so that for newborns, these are critical. And these interventions should be taken to scale beyond pilot sites. So for us to achieve SDG 3.2 in the newborn period, there is the urgent need for improved accessibility, affordability, availability, acceptance of oxygen therapy across all levels of health service delivery. And for this, we need to run fast and 10 times faster. Thank you very much for listening. Thank you.
Wow, wow, wow. Love that last slide. That was Professor Chinyere Eziaka. So I don't think any of us, after hearing that, will speak about newborn care without saying oxygen. That is an incredibly persuasive and compelling case. Thank you very, very much.
Thank you.
And we will make these slides available to everyone tomorrow. You have everything in that presentation you need when you're advocating for oxygen in the context of newborn care. So Professor Eziaka has done our work for us. Thank you. Now, in the interest of time, please drop your questions into the chat. We may be able to come back to them, but I just want to have our last speaker on, and then we should have a good amount of time to pick up some questions. But please drop them into the chat. Yes, you're getting applause there. Well deserved. And we'll come back to Professor Eziaka. But I want to bring in our final speaker, because Dr. Eziaka made a comment in her closing remarks about the cost of medical oxygen and the high out-of-pocket costs that many patients are paying. So if you can just stop sharing your screen, and we'll take that slide down, and we'll bring in Dr. John Fogarty. Dr. Fogarty works for the World Health Organization, and it's extremely appropriate he's our final speaker, and we give WHO the last say here. They have stepped up, to put it mildly, on access to medical oxygen since COVID. There are so many things the WHO is doing now that they weren't doing prior to COVID. We have a medical oxygen resolution from the World Health Assembly. The International Pharmacopoeia has been updated. A lot of guidelines have been updated. The WHO just led a huge meeting in Senegal, bringing, I think, more than 60 ministries of health together to encourage them to come up with national medical oxygen plans. And there's more. But overarching all of this is the WHO's big agenda for universal health coverage. And we wanted you to hear from Dr. Fogarty, particularly about that SDG, but he's free to talk about other areas as well. Because we've heard time and again, and we're still hearing it, about the money, the amount of money patients are being asked to pay for oxygen across Africa, Asia, Latin America, parts of the Middle East. I mean, massive amounts of money, and they're denied care if they can't come up with the money. So UHC and oxygen is a huge area where we need to focus, and we wanted to bring Dr. Fogarty on to give us some guidance on how we take on that massive agenda. So over to you, John, and thanks for joining us.
Yeah, thank you so much, Leith. I will follow up on many of the great points that have been made by the previous speakers, and as you say, go kind of to the higher level of universal health coverage. So looking at the approach that countries are taking to be able to support oxygen delivery and to make sure that the people who need oxygen are getting it where they need it. So I'm going to talk about universal health coverage. So we're going to go up kind of at a health systems level. For those of you who don't know what universal or haven't heard specifically about universal health coverage, it is defined as ensuring that all people have access to the services that they need, when they need them, where they need them, and then importantly, as Leith was just mentioning, without financial hardship. And so as part of the SDGs, target 3.8 is that all countries are working to make progress towards universal health coverage. However, we're off track right now. There was a global monitoring report on UHC that was done last year, and it showed that 57% of people, or more than 4 billion people, lack full access to essential health services. And importantly, again, following up at the point about financing, that about a quarter of people face some financial hardship because they don't have access to the services that they need. So responding to United Nations last September, brought together all member states and issued a UN political declaration on universal health coverage and calling for UHC for an additional 1 billion people. As the UN's health agency, WHO has been tasked with supporting countries to make progress towards UHC. And there's many different ways that WHO supports countries in making progress towards UHC. I'm going to highlight one that we have been working extensively across many countries to be able to support them. But specifically, one of our tasks is to reach the most vulnerable. So when we look at health service coverage, it actually started slowing back in 2015, and it stalled completely in 2019. We also, and this kind of hits on the point that Mike and Leith both made about the importance of non-communicable diseases. So countries right now are facing many countries facing a dual challenge. So they still are trying to provide services for communicable diseases, for sexual and reproductive health, but they're seeing a rise in non-communicable diseases. So making sure that they have the services and the resources, including oxygen, to address some of the rising NCDs. And then lastly, it's very important that we're working with countries to be able to ensure financial protection. And we've seen a rise in a loss of financial protection in the last 20 years. So what do we do? How do we address this? What do we do now about this? Well, WHO has been working for many years to be able to support countries as they are. Sorry, just one second. Can you still see my screen? It looks like it interrupted. Leith?
No, we can see. It's good.
Oh, you can still see it. Okay. So one thing that is really important is that no country, even a wealthy country like the United States, can't provide every possible health service to everybody who might benefit from it. So it really is the prioritization of a subset of services that really is important for universal health coverage. I think of it, my father used to tell me, if you don't know where you're going, you might end up there. And if you don't know where you're going, you might end up there. And if you don't have a package of services, if you don't have an explicit package of services to define what services are being delivered, where they're being delivered, who's delivering them, what resources are required, it's hard to know how to get there. So we've worked with many countries over the past several years to be able to support them in designing a package of services, and we've learned a lot. We've learned that packages are very powerful. So they may get used originally to define, say, a benefit package or an insurance package, but they also get used for other purposes, like ensuring contracting accountability. So we saw this in Afghanistan, where many of the services are delivered by partners or contractors. A well-defined package makes sure that there's accountability in what services are being delivered. It also is important for the health workforce, making sure that the health workers are trained to be able to deliver those services. So we just heard from Dr. Azika talking about the neonatal care, making sure the workers have those competencies. And a package can help that. And then also, very importantly, making sure that the medications, the devices, the products that are needed for universal health coverage are available. And then thirdly, and this is fairly obvious, but it oftentimes is something that is challenging, is you can define a package, you can make a beautiful package, but it doesn't have any impact unless it's implemented. So some of the things that we do is to work with countries to design a package that can be implemented. And I'm going to show you some specific examples of some of the tools that we've developed. But currently, we're working in supporting countries in developing a number of types of packages of services. So we're working extensively and increasingly in humanitarian settings. So defining those resources and services that are needed. We've most recently been working in Myanmar, Cox's Bazar, Moldova, Sudan, most recently in Gaza. We're also working with countries to help them define a package of services, a national package for universal health coverage. And then oftentimes countries may look at program-specific services that they might want to deliver, say, for palliative care or primary care. And again, oxygen, and explicit inclusion of oxygen can be very important. So WHO has been working for the past 5 years to develop a resource called the Service Planning, Delivery, an implementation platform which supports countries to be able to take a structured approach to planning for a delivery of a UHC package. You can find it at uhcc.who.int. You can also scan the little QR code up in the corner, and you can have access. If you would like more information, at the end, I'll share my email and you can reach us. I'm going to show a couple screenshots. This is from an actual package from a country. This is the platform, and again, we've been working with many countries. This is a package that was just passed actually this month by a country, and it's going to Parliament for ratification. So there's a structured architecture for countries to consider all health areas. So, for example, NCDs, or in this case, communicable diseases. I'll show you an example for services for pneumonia, but again, countries explicitly considering the services that they need for all health areas. So in this example, there's services for prevention, screening, diagnosis, the management of pneumonia. And I heard some of the speakers talking about the importance of pulse ox. In this example, on the left-hand side, there's a list of services that were considered. On the right-hand side are the delivery platforms where the services are being delivered. And you can see in this case, this country actually adopted education on home-based pulse oximeters at the community level, the health post level, the primary care level. And then also they included oxygen. They weren't able to include oxygen at the kind of the health post level, but they are including oxygen at the primary care level and the hospital level. Similarly, and we heard about the importance of NCDs being addressed. So countries are taking, again, a structured approach to consider all health areas that might be included in a package. So looking at cardiovascular diseases, in this case, respiratory diseases. So making sure that there are services explicitly for COPD. So services for the management of acute exacerbation, longitudinal management. And again, in this example with this country, supplemental oxygen was again included for the management of COPD. In the resource, there's also links to the diagnostics tests that they might need, the medicines, and links to WHO databases. So this links to the essential medication list. There's also links to WHO references, allowing countries to kind of have one-stop shop to be able to find the references as well as the resource requirements to be able to deliver the services. So this is an example showing the links to WHO package of essential NCDs. One other example, again, it's important to make sure that oxygen is explicitly included for management of many different disorders. So NCDs or communicable diseases, as well as for injury. And again, we've seen this where in some countries where oxygen was only designated for management of COVID, and it was really important to make sure that it was explicitly available for other conditions. A well-designed package also supports a model of care, meaning defining explicitly what services are being delivered, where they're being delivered, who's delivering them, what are the material resource requirements, so what are the medications, including oxygen, what are the devices, what are the kits, sets that are needed, and defining where they're being placed in the health system. I can give you a couple of just quick examples of some countries where we're working currently. United Arab Emirates is currently looking at individual packages and bringing them together to make sure that they're defining services for their entire population, including the immigrant population that's at UAE. We just completed work with Kyrgyzstan, where they defined a national package for universal health coverage, which included the integration of oxygen services and devices really across the whole health system, from the primary care level to the hospital level. Sierra Leone is also currently looking at how they can improve the care and delivery of services for emergency, critical, and operative care. Obviously, oxygen therapy and oxygen devices are critical to that. And then we're currently working to support Ethiopia in defining a package of services for humanitarian response, and including in that also services for oxygen. So that's a quick, a very quick overview of universal health coverage and some of the work that is ongoing to be able to make sure that countries take an explicit consideration of services for oxygen across diseases, across conditions, across delivery platforms to make sure that those services are integrated. So I'll stop there and back over to you, Leith, and really nice to join you all today.
Yeah, that was amazing. So that, when you just took us through the UHC planning and packages, is that set up open? So can people go to the WHO website and just play around in that? Obviously no country data, but is it available to the public to just look at the way it's set up?
It is, and there, if you want to actually, there's like a little playground that you can. So if you ask for a user account, and you can do that on the homepage that I listed there, it'll send it to a message to our team. We'll make a user account, and then you can actually go on and you can actually learn how to use the tool. If you have a specific application in a country, we can actually work to set up a training. So some countries are doing kind of a systematic assessment for specific conditions to make sure that all the services that are needed are available.
So as advocates, if we know some of the countries we work in are considering or reconsidering their UHC package, we could encourage them, first of all, to use this tool. And because oxygen does seem to be well integrated in each of the different areas, that this is a tool where they won't miss oxygen. If they use this tool, they won't miss oxygen at any critical point of the health system.
Exactly. So that is something that's really important, is that they take a structured approach to consider all health areas. And so they're they're explicitly reviewing and considering and including or potentially excluding services, but they're making that conscious decision.
Exactly. Perfect. So we need to be advocates for this tool. So this is a new thing for us to get behind. So thank you for sort of unveiling it. I think a number of people are fascinated and want to dive in. We'll give you details tomorrow in the big email about how to do what John just advised if you want to dig deeper into that tool. I can see Dr. Esiaka is answering her questions in the chat. We can take one question for John if there is one on UHC and oxygen. If not, we're going to encourage all of you to take a look at that tool. Another thing, you've just given us some great case studies. When a country does use the tool and they do, introduce or cover pulse oximetry and oxygen, how do we know? So that would be the country would then go to the political bodies for endorsement. They would announce it, and at that stage, would we be able to come in and say and applaud the country, for example, for X, Y, Z? It's hard often to get information on what governments are doing with their UHC packages.
It is, but I think increasingly countries are becoming more transparent about the services that are included in a national package of universal health coverage. I didn't share the country on the example that I shared just because it's still going through the kind of the final approval. But when a country does approve a national package, it's certainly a great opportunity to be able to engage and applaud them. Countries are also using this platform to be able to do an assessment, so to make sure that the services that they've defined in a national package or a program-specific package actually are being delivered.
Brilliant. Okay, terrific. So what if we go through, we've got some very eager people in our network. What if they go through this and find a place where oxygen is not indicated, but the data says it should be? What should we do? Or do you think that's not going to happen because it's very, very comprehensive?
It's a massive database. Let me tell you that behind the scenes, this has about 4 million data points, and it connects. But to plan a health system from all the services that are needed to all of the specific products, the health workforce data, it's a massive undertaking. So we would definitely welcome any feedback. Again, you can contact us through the website that we listed there, and I'll go ahead and put the website link again into the chat.
Terrific. Thank you very much. So we have a final question for you from Kim Hong Gove. I'm going to ask you to read that and answer it in the chat, John, and then we're going to move to, we've got a few updates from some of our members and then we'll close. But I want to thank our 4 speakers. They were 4 totally stellar presentations. But we have a couple of updates and I want to call on Victoria Jacqua to give the first.
Thank you, Leith. For those of you who don't know me, I'm the medical community lead for open source medical supplies, and I'm a founder of the Global Open Source Quality Assurance System, and I'm a board member of Public Invention. All of our organizations focus on open source solutions to medical issues, whether it's distributed manufacturing for medical devices or tools to help medical professionals anywhere they are in the world. So I just wanted to talk about a really amazing innovation that might revolutionize the way oxygen is made and delivered. I know that, Leith, that you know about this because you've connected with Dr. Reed, the director of Public Invention. But over the past year, NASA has been developing a new oxygen capture technology, which is based on a ceramic ion transport. When this membrane, the ion transport membrane, is heated, it allows a voltage to pull only oxygen ions across a membrane. And the tool that is used for this is literally a ceramic tile, such as the kind that you would put on your floor. And Public Invention's role in this project has been to develop a open source software control system, which controls the heat and the membrane amperage to produce bottle-ready O2. Public Invention continues to work with NASA on this project, and it is ready for technology transfer, meaning it has been proven in a lab. NASA knows that it works for their purposes, which is to provide oxygen to an astronaut within their spacesuit. But it has enormous humanitarian possibility for many different reasons. As we know, PSA and liquid oxygen plants are extremely expensive, difficult to maintain, and are subject to a lot of environmental issues, including brownouts, surges, diesel fumes, dust, heat, humidity, all of those things. And this technology, the ceramic ion transport, has no moving parts. It requires no maintenance. It passively creates oxygen, and it can produce 100% pure O2. And the energy required is about 1 watt-hour per liter. This has been proven in the lab. So we believe that it has enormous potential for solving a lot of the problems of especially rural oxygen capabilities.
Just 1 minute, Victoria. Sorry to hurry you.
Yes, ma'am. So we are interested in connecting with groups and organizations who would like to discuss creating a pilot project so that this technology can be proven in the field.
So you're looking for rural hospitals in low resource settings?
It could be. We could also partner with a university. We would like to partner with an LMIC, but of course we are also open to partnering with anybody in the United States or a higher income country. We just want a pathway to start this technology transfer.
Okay, that's clear. And we will put this in the email tomorrow. And also we're going to have this team back on, Victoria, in a future call. We're going to do another deep dive. We've done a couple of deep dives into this technology in the past, but it's been a while. So we're going to host a special call in the future just on this.
Okay, fantastic. And I'll let Dr. Reed know.
Yes, so John Graff at NASA and some of the new venture partners, I just put the link into the chat. Novair and American Oxygen, 2 companies, are now taking a look at this. We may have you back on to talk about how you're contributing, but rest assured, it is a very, very promising innovation. We will be covering it in depth.
Yes, ma'am. Thank you so much.
But in the meantime, if you like what you hear here and you want to, Victoria, you want to put your email in the chat and you want to learn more before we bring it back to you, please email Victoria if you want to follow up on what she just said. Okay, any other urgent issues for any of the members on the call? Any updates? With 1 minute left, anyone? Or please feel free to drop into the chat. If not, I've just got a couple of things and we'll finish at the 12:30 mark Eastern. So as usual, we send out a big email tomorrow. I've alluded to it several times. We bundle all the information you've just heard into 10 key actions that you can take to turn what you've heard today into real action on the ground. So look out for that. We'll also give you a direct link to each of the speakers so you can follow up with them directly. We really like you to do that. We encourage you to do that between our calls. So we don't just speak and then nothing happens afterwards. There's too much of that happening. There's amazing things going on in the world of oxygen. The Global Fund is installing new oxygen plants in many countries. UNICEF has just installed the first fully solar-powered oxygen plant in partnership with one of the state governments in Nigeria. There's just a lot of stuff happening now. A lot of this was COVID money, and it's finally making its way into real products on the ground. We'll share some of that with you. The Lancet Global Health Oxygen Commission is about to be submitted for publication, a huge 18-month effort. Many of you have been involved in that. The goal is to publish that in early 2025. We have a World Health Summit event this October. The World Health Summit, the big gathering in Berlin, has given us some time to talk about oxygen, which is the first time we've brought this issue to the World Health Summit. So stay tuned for more on that. This was the second of 3 calls we're hosting this summer. Our final one is on oxygen and climate change, which is a greenfields area. We're going to bring the latest science to you and some of the latest actors. So please look out for the invite for that. We've recorded this and we'll share that with you as well tomorrow. But a huge thank you to all of you for sticking with us. We know it's getting into summertime in the Northern Hemisphere. Thanks for sticking with us. Thanks to our speakers. And we hope we persuaded you that oxygen, unlike many, many medicines, ticks so many SDG 3 boxes that we really have to make faster progress closing the gaps that remain. Thanks, everyone. We wish you a really terrific month, and we'll see you again next month.